Firstly, a sort of disclaimer from my part is I'm going to try and talk about suicide as truthfully and honestly as I can, but that means that you have to look after yourself. And you have to be responsible for your response to what I'm saying. If it's too much, please take yourself away, or do what you need to do to look after yourself. Because what I talk about can have quite strong resonance at times. And maybe also before I start, what I'd just like to do is ask you if you could put up your hands if you've had either personal or clinical experience of suicide. Okay, so I'm going to ask you to put up your hands if you haven't had personal clinical experience of suicide. Yeah. So actually, this is what I see normally. It's by probably at least 3/4, if not more, people that I talk to have had personal or clinical experience of suicide. So I think it's again very important, I think, to have that on the surface and have it up there. So that a lot of us have had lived experience. And you can't separate either between clinicians and family members, because there are lots of clinicians who've had family members who've died by suicide. So we are together in this. So before I start, what I think I'll do is talk a little bit about my experience and why I'm talking about suicide in this way. So I'm a consultant psychiatrist, and in 2008 I had my first inpatient, I got my first consultant job. And I was really pleased. You know, medicine, you got one rung at a time. It's a bit like being in the army. And finally, you get to be a consultant. I was absolutely delighted with this job. It was in an organisation where I trained with people that I loved, their colleagues that I loved. I was absolutely delighted in a job that I wanted, inpatient consultant. So my second week, second week on the ward, my first patient died by suicide. In the third week on the ward, my second patient died by suicide. Then a few months later, about 3 or 4 months later, we had a horrendous inpatient suicide that was treated by the police as a murder initially. And what I found out is that that's not uncommon. And I think there was probably something in the first, and it's very common to people who work in mental health services and hear about suicide. It's sort of said to you as an aside. If someone mentions it, you might get an email. It was actually one of the nurses, one of the junior nurses in the ward, who just happened to say, "Oh, did you hear that so-and-so, who you discharged last week, has died by suicide?" And at that point, nobody really knows, but the assumption's already made. And I think there was something about that experience, in that moment of finding something out, that something in me died. And I think it was killed, but something in me died, and that part of me has never recovered. It hasn't come back to life. However, that probably set a train in motion for me and has determined my whole career. So I thought I was going, this sort of first death, really something in me died. The second death really just compounded that this was the new reality that I was living in. By the time the third death happened, I was drowning. And I don't know, as very common to doctors, we have this capacity to split. So one part of me could carry on going into work, and I could arrive at work, and I could appear to function. But inside of me, I was in abject panic, absolutely dreading going into work, terrified of the patients I was seeing. I really didn't know who was going to die. Everybody looked like they might die to me. I found it absolutely terrifying to make decisions. And at that time, which was 2008, hardly anybody talked about suicide at all. And I think one of the most a colleague said to me was another consultant who said, "Oh yes, the first year can be tough." And that was it. And I felt ashamed, humiliated, isolated. I felt there must be something wrong with me. Why would these patients die in this way? I must have done something. That there was something toxic about me. And when I was at home, my children were small. I didn't want to be with them. Like if I went to be with them in a bath, I thought I was something deadly. I was exuding something deadly. And I thought my colleagues must be looking at me and thinking, why did we give her a job? You know, she can't, this is just terrible. But luckily enough, I bumped into 2 other colleagues who were going through very similar experiences. There was a liaison consultant who'd had 6 deaths of patients by suicide in the last year, and a community mental health team consultant who'd had 4 in 4 months. And we were all in a very similar state, and it was a bit as though we had managed to grab each other in a tsunami and we just hoped one of us was holding onto a tree. And what we decided to do is ask Rob Hale, who had been the director of the Portman, and had worked on suicide, and I've known from a different setting, to come and, he's a psychoanalyst, to come and work with us every month. So we formed this group, and we'd meet every month, and it was about trying to process our own trauma. So if that, and also at that time there was something about, we couldn't be seen to be doing this. We had to hide this group from the organisation we were doing it in. So we met every month, and in that year, the moniker of the group, or the aim is benign, compassionate interest. So it's not about trying to say everything will be all right, or we know what's happened here. It's about, well, let's talk about these deaths. Let's talk about your experience, also your experience of it, and let's see what we can learn about suicide in this. And in this year, in the next year, it was as though the water level went down, and I found I was still standing on land. So I thought there's something going on here about actually trying to talk about suicide, trying to face it, trying to work out what this means, because there was so much nonsense being talked about suicide, I can't even tell you at that point how nobody could say anything sensible about suicide at all. But gradually you start thinking, oh, there are some patterns here. This is interesting. Patterns not only in the deaths, not only in what happened before, but patterns in our own responses afterwards. So that started me thinking about suicide and thinking that for me, the only way out of the trauma, and I know in retrospect I had a post-traumatic stress disorder, as I know my colleagues did, that the only way out of this was through. So since that time, we're still running this group, and it's been opened up to all consultants now, and it's suicide and homicide, and we've heard at least 100 cases of suicide and homicide now. And I've been working probably since 2008, about a third, if not probably now a half of every week on suicide in my own time, not just in my own time and space, and have left the NHS very largely, well, for various reasons, but one of which is so that I'm free to be able to talk about something in the way that I want to talk about it. And I think organisations can shackle free speech in a way. So what I'm going to share with you today, there's two parts to the talk, and I'll pause after the first part for some questions, and then I'll do the second part. And the first part is what I call 8 truths about suicide. And the second part is going to be the effect that suicide has on clinicians, the effect patient suicide has on clinicians that we've seen. So I'll start by talking about these 8 truths. Now, what these are my truths. What I would say is, look, you do not believe what I'm telling you. Work it out for yourself. Look at the data. So much nonsense is talked about suicide. Look at the data yourself. For example, the suicide rate has stayed pretty constant since about 2002. You know, bit up and down, pretty constant. And that's a difficult thing for us to look at or try and face. But I'll share the different truths, and I've summarised different areas about suicide that seem to hold true to me in the work that I'm doing, which I'll tell you a bit about the work that I'm doing. But I just want to first start by a quote that stayed so much. There's 2 quotes I'm going to share with you. And this one has really stayed in my mind, and this is from Camus, which is, there's only one philosophical question, and this is suicide. And I think there's something about that, because people say, well, don't you get depressed doing this all the time? And I say, it's the opposite of that. It's actually the opposite of depression. There's something about really trying to focus and think about this that is about life. So that's the first quote, because I think he's right. It absolutely seems that there's something about suicide that is at the heart of everything that it means to live. And this is just something else that I found, and there's an awful lot that I found for myself, which is the only way for me out of the trauma, post-traumatic stress, was to face the trauma and go through it. And I think this is well understood now, I suppose. There's a big emphasis on what's called post-traumatic growth. But the trouble is if something is stigmatised by the local environment, if you're humiliated or feel ashamed because you've had a patient die, then what happens is you turn away rather than face and talk about it. So it sustains the trauma in us, in our systems, in our organisations. And in the work that I've done, I've had people who will come up to me and say, I'm going to tell you something, and they tell me about death by suicide 20 years ago, and they'll say, I've never talked about it before. And this happens all the time. Okay. So this is just some of the work that, this is just some of the work, just a bit my pathway through the work here. So I've been doing audits in all the mental health trusts I work in on the deaths by suicide. I became the first in the country, I was the first suicide lead in the country for Barnet, Enfield and Haringey Mental Health Trust, and that was because I was driving them mad, and they just said, oh, just be our suicide lead then. And that was very helpful because it gave me authority to do what I wanted to do. I became the Serious Incident Review Group Chair for Haringey for 4 years. I then became the clinical lead for the British Transport Police Suicide Prevention Team, a founder member of the Haringey Suicide Prevention Group, which I have to say I'm very proud of the Suicide Prevention Group. It's a multi-agency suicide prevention group run by the community and not by public health. Public health are a member, but they don't run it. I've been running the suicide group for consultants for 13 years and doing lots of other workshops and groups. I was very lucky to get to the coroner's office to actually be able to look at all records of deaths by suicide. So after people had died, look at all their records for a year, which was incredibly valuable for data-wise. That I'm now the lead in the Royal College of Psychiatrists on suicide. I'm the chair of the Patient Safety Group and the chair of the working group on the effects of patient suicide and homicide on psychiatrists. And we're writing guidance for all mental health trusts for the pastoral care of staff after death by suicide. Member of the National Suicide Prevention Alliance, wrote the suicide strategy. I worked for the Priory Group for a while and wrote their national suicide strategy and led on that. And I'm doing and still doing a lot of research with the Oxford Centre for Suicide Research. And we've done a booklet which I should circulate for you for, well, it's the first one's for psychiatrists and we're doing one for all clinicians to help host it after a death. So that's how caught up I am and how involved I am in this as a result of what happened to me. So, I think I'm going to So this is another second quote. This was the chaplain at Beachy Head. So in one of the first workshops I ever did, I met the chaplain at Beachy Head. And he'd been working there for 20 years. And he said this to me. He said, to help a truly suicidal person, you have to approach them with an open heart. If you're worried about the effect their death is going to have on you, they're more likely to jump. Which is actually, I mean, having worked in mental health services, how terrified we all are of what's going to happen to us if a patient dies. This is incredibly profound, I think, and very meaningful. So, first truth, okay? The first is that suicide is not an accident. And I think we can, I mean, certainly within mental health services, we can treat suicide as though it's an accident, that we've left something out and someone's tripped over it. Now, suicide is not an accident. It really is not. It results from extremely complex, universal, unconscious mental mechanisms that we don't understand. It is a very complex, multi-layered action. And the etiology of suicide probably starts in the womb. Yeah, so suicide is not an accident. It does not happen due to our negligence. It can be highly determined in that, and that has two meanings. People can be very, very highly determined and creative when they want to die by suicide, but also it's got much unconscious meaning. It's a highly determined act. So often the actual act itself has very profound symbolic unconscious meaning for the person that's died. So that it's a result of complex, probably universal, I think universal undoubtedly, unconscious mental mechanisms that we do not understand yet. And it's amazing how much we don't understand and how much there is a lack of curiosity to try and understand it. So actually it's only psychoanalysts that have really tried to write about these mental mechanisms. So there's a fantastic book by Rob Hale and Don Campbell called Trying to Understand the Pre-Suicidal State of Mind, called Working in the Dark. And it's the only really contemporary attempt to try and understand something. And as Rob Hale would say, it's amazing, isn't it? Because we've had a whole loads and loads of articles on suicide, but it's observational work. And it's as though trying to understand heart disease by observing what happens to people rather than trying to understand what goes on inside them. And there's so little work on what goes on inside someone's mind. Yep, so it can be highly determined. Okay. Number 2, suicide appears to be, and I'm saying appears to be because we don't know, either impulsive, and I'll give you some examples, the most amazing examples of impulsive suicide. There's a bridge that is particularly known for it in South America, where people walk across it. I mean, there's multiple different stories recounting people walking across it with their friends after a night out, and one of them just leaving the group, standing up and jumping off. So extremely, without any warning whatsoever. In London Transport Police, what you'll see is, because they had CCTV footage, what you'll see is people having an argument and then jumping in front of a train. Husband and wife have an argument, wife goes outside, husband locks the door and takes his life while she's outside. So what appears to be impulsive. Now I'm going to show you a little video which ends well, which demonstrates what I'm trying to say. Let's hope it works. Okay, so this is circulated very widely on social media. And what this is a man here, and he's talking on the phone. You can see him over there. So he's on this side and he's talking on his telephone. And there's another couple of people walking further down the platform. Let's see if this works. So here, he's talking on the phone. He's had an argument, he's furious. So I think very evidence of what it is that I'm trying to say, that suicide can appear to be impulsive after this sort of event. Very common. And what is more problematic, I think, for us, is that suicide can also appear to be premeditated. So what you can see from the coroner's records is clear planning of suicide that can go on for months, if not years, before the death, without anybody knowing. And I think this is, again, difficult for us to understand or to try and make sense of. How does this happen? And it can happen in very disturbing ways. It can happen in very straightforward ways, so that you can find out that someone has actually got rid of all their belongings, written letters to the coroner, tidied up all their affairs before their death. But it can happen in more disturbing ways. So, for example, a man who might have stripped out the garage and rebuilt it as an environment in which to take his life over at least a 3-month period without his wife knowing. So there's this sort of premeditated aspect, clear premeditated aspect to some deaths, which also is one of the things that, if you're looking at it, needs to be considered. And what does that mean? What does that mean? And I'll say a little bit about what I think it means in a minute. This is number 3, and it's a really difficult one to try and communicate to people within mental health services. Is you do not know what is going on in someone else's mind. And I think we function as though we do, that we should know, we do know, and if we don't know, we're at fault. We should know what's going on in someone else's mind. In reality, you do not know what's going on in someone else's mind. Unless they tell you, you're not going to know. But also the reality is you don't even know what's going on in your own mind. And the truth, I think, for a lot of people who die by suicide is they don't know what's going on in their mind either. And they don't even know that they're planning it. So someone can really plan it within one part of themselves, and another part of them does not know that this is happening. There's a profound internal split. So very difficult, and I've had very, really quite intense arguments with people in mental health about actually, and it's obvious really, how easy is it to predict anybody's behaviour? Can you predict your own behaviour? What is the chance of you being able to predict someone else's behaviour, particularly when you're talking about a rare event? This is the next point, that from the data, everybody is surprised by the death. Everybody. The majority of deaths by suicide do not happen within the mental health population. So the National Confidential Inquiry, 75% around of deaths by suicide have had no contact with mental health services in the last year. And the coroner's records also indicated that this was the case. That doesn't mean that we don't have mental health problems, but there's been no contact with the mental health services. And it appears from the records that they have no mental health history that is documented anywhere. And so this presents us again with something that's very difficult. That everybody's shocked and surprised by the death. So it's well known now that risk assessment tools do not predict the risk of suicide. That actually most people who have had contact with mental health services, and there's been a risk assessment, have been rated as low risk at their last assessment. And even if someone is chronically suicidal and unwell, people are not necessarily expecting the death to occur at the point that it does, and people can appear to get better before they die. Again, this is now well accepted. That suicide is a human condition. It's not, if we try and claim it to ourselves within mental health services, we're not looking at something and we're biasing what we're seeing. Is the majority of death by suicide happen within the population that is not in contact with mental health services, and this may indicate that this is a result of being a human condition, not a mental health condition. There might be similar etiological factors within mental health and suicide, but that suicide occurs in the population without any mental health problems at all. And to speak to what we know, or we're starting to know or understand about suicide, what it appears to be a result of is an incapacity to mourn. So that there is very often life events before someone dies, serious life events. And if we think about it from our own perspective, there probably are losses where we could clearly think, well, actually, I might not survive that loss. I know something happened to my children, I'm not sure I will survive that loss. So, you know, that suicide appears to result from an incapacity to mourn. That might mean that the loss is too big, or the capacity to mourn is too low at that particular point. So if a psychiatric diagnosis is wanted, then that of adjustment disorder would be the most fitting one. So there's been, again, very little coherently written about the pathway to suicide. This is Rob Hale and Don Campbell's pathway to suicide. I'll describe it very quickly, and then I'll say from the coroner's records, did this match up with what we saw at the coroner's records? So, what they argue is that there is a pre-suicidal vulnerability, either temperamental, someone can be born with a vulnerability, or environmental, or a combination of both. And what the difficulty is that there has been a problem with mourning throughout life. And this is maybe hidden, so it's not seen, but results in a sort of vulnerability within the personality, this sort of division. And there might be many, many of us, like I'm saying, in medicine, doctors have this ability to split and function in two separate ways. So many of us might have this pre-suicidal vulnerability without going on to die by suicide. But in those that do, there is, so someone might have a real problem with mourning that's hidden, and they can be functioning at a very, very high level. But then they have a loss event, a significant loss event. And because of the difficulty in mourning, the destructive energy from the mourning process doesn't get released into the external world and is held internally, causing internal disturbance. There's then what's called a pre-suicidal state, which is a sort of quasi-delusional state of mind. And their argument is that when someone is planning their death by suicide, they don't really think they're going to die. There are unconscious fantasies which are in their mind that they will go on, and merging is one that underpins a lot of this, that I'm going to go and join my mother who died, I'm going to go and join my sister, I'm going to go and be with someone I've lost. So this idea of merging, and if you think that people travel from all over the world to die by suicide from the Golden Gate Bridge, you could see this fantasy of renewal starting again that may come into that death. So this is the pathway to suicide. Then there is a lot of people, again, might enter the pre-suicidal state and not go on to die by suicide, but in those that do, there is a small loss event called a trigger event that occurs very close to the death and is experienced as the person who is in the suicidal state as final proof that nobody cares and they're given permission to act. Then there's a dissociative state, what's called a state of true ambivalence, it's a sort of dissociation, and then an act. Now, there could be a long time. This last stage can take quite a long time, so in the CCTV footage, people would be filmed over 24 hours going up and down tube stations, one up and down, and on the Golden Gate Bridge before jumping. And this is thought to be that people are actually switching from one part of them that is planning this to another part that is not. They're actually in what's called a truly ambivalent state. So there's a final loss event of dissociation and then an action. And then what is very sad about this is that once the point of no return is passed, at least in some cases it is thought that at that point the dissociation resolves and there is a regret, but nothing can be done. So the very, very famous quote of the man that jumped off the Golden Gate Bridge, as soon as my hand left the handrail, I realised that everything in my life was fixable apart from the fact that I'd jumped. And this was a comment from Campbell and Hale, that suicide freezes the relationship in the zenith of its sadism. Now, sadism is a very normal part of any relationship. Yeah, so we're all locked in various sadistic relationships as part of our normal relating. But the trouble with suicide is it's frozen in this place. So when I'm talking to people who say, I do not believe in suicide prevention, which isn't at all the case, I absolutely believe in suicide prevention, but sanity about suicide prevention, not fantasy. So suicide prevention is challenging in any individual case, and I have to say from my honest testimony, I have seen much more evidence that suicide is not predictable and preventable in any individual case than I have evidence that it is. And I have to speak to that. However, there is very good evidence that suicide prevention on a public health, on a population level, absolutely works. So if you reduce population-wise access to means, the suicide rate drops. So it's a public health intervention that works. And of course, it's very likely that those of us who work within services prevent a lot of deaths by suicide, but we can't have any evidence about that. So this is clear evidence that if there were if we had barriers like this at train stations, it would reduce the suicide rate. But we've been campaigning for that and it's too expensive. So, but suicide, this is the other aspect of suicide prevention from why I'm here, is that suicide, as you could see with that man, that he was immensely distressed. And instead of being able to say or express his distress, he acted. That suicide is an acting out event. That if we can talk about it and put what our distress into words and try and take part, try and open up. Someone tells you they're suicidal, this is a gift because it allows for an opportunity for exploration. Suicide is a very condensed word. It's I say particularly with men, that actually men will say to me, I'm absolutely fine, yeah, absolutely fine, absolutely fine. And then you ask them, have you ever thought of taking your life by suicide? And sometimes it's a bit like asking someone who drinks a lot of alcohol, do you drink a lot of alcohol? There's a question that sort of makes its way through. And it's so many times that I've seen a man saying to me, I'm fine. Have you ever thought of dying by suicide? And then actually tears come to their eyes. It's like, yes, I have actually. And it's like an umbilicus into someone's distress if you can talk about it, and it's a gift. And if you can talk about it, in all theory, would indicate that if you can talk about it, then someone is less likely to act. And the trouble is, if we're frightened of suicide, it makes it much harder for us to talk about it. So, I'm just going to sum up these ones, and I've got one more, the most important one that I want to share with you after this. It was the one I would like you to remember. So, suicide is not an accident. It's the result of complex and probably universal mental mechanisms we don't understand. And you will never know why someone has died by suicide. You won't know. You just won't know. And it's unbearable not to know. And so what we do with not knowing is we create a narrative. And that narrative, I know now, it was because of social media, it was because of that, and now I don't have to think about it or deal with that uncertainty anymore. You don't know. And even the person themselves, from the evidence that we have of people who've survived very serious suicide attempts, or looking at suicide notes, it's not coherent. And even the person themselves might not have a coherent reason about why they're doing something so extraordinary. It appears to be either impulsive or premeditated. You do not know what's going on in someone else's mind. Everybody is shocked by the death. It is a human condition and not a mental health condition. That it appears to result from an incapacity to mourn. And that suicide prevention is both a public health issue and all of our responsibilities to talk about it, to face it, to try and communicate and not be frightened about talking about it. The final point from this part, the final sort of fact or truth, is this one. The most important point: no one is to blame for anybody else's death by suicide. This whole concept that underwrites the organisations that a lot of us work in is utter fantasy. It makes absolutely no sense on any level whatsoever. That how could anybody be to blame for something that somebody else does, firstly. But secondly, blame is a non-mentalising word. So if I don't know if people work in mentalisation services, but when our minds are overwhelmed by anxiety, our capacity to think collapses and we go into a non-mentalising state. So we're all in a non-mentalising state at the beginning of the pandemic. And you go into this world where it's either this or that. It only could be one or the other. So it's a non-mentalising state. And blame is a word that comes out of that non-mentalising state of mind. And what it implies is one causality. It's you. It's either you or me. And please let it be you. You know, and people fight. You can feel that this divides services, divides teams afterwards. Please let it be my colleague and not me that gets this. But it makes no sense. Because again, as I'm saying, suicide is a very complex etiology that we don't understand, multi-layered, multi-dimensional. There is something different about responsibility. We can all share responsibility. We all have some responsibility to talk about suicide, to think about it, to try and face it. We all have some responsibility which we can engage with. That is not the same as blame. Blame is a route that we try and take to avoid having to think about it. It's another word for scapegoating. If we can blame somebody, phew, that's the story. The story is it's you did it, phew, I don't have to think about it anymore. So, that's just, and this is just a quick summary before I'll pause for some questions. It's our belief, I think it's our belief that we can predict and prevent individual suicide that makes us the architect of our own downfall following the suicide of a patient. We then take the suicide of a patient as our own failure. The truly suicidal then pose a risk to us, and it makes us much, much less likely to approach them with an open heart. So what I'm going to talk about now is this is work and research, just summarising some of the work, and maybe this also speaks to some of the questions a bit about the effect within schools and things as well. So the effect a death of a patient by suicide has on clinicians. And this is a quote from a Henry Marsh book by a surgeon called René Lariche, that every surgeon carries within himself a small cemetery where from time to time he goes to pray. Now I think this is the same very much within mental health or in probably schools or in other environments. There are people who've died by suicide that reside with us. I know my patients do, and they're there all the time every day. And someone said, well, it's worse for environments we work in because we get to know people much better than the surgeons do. The effects of patient suicide often has a very powerful effect on the clinicians involved, and I think here we're talking about schooling as well. Everybody is involved. But what happens after a suicide is people get what's called, the people who are involved, who often aren't direct family, can get something called disenfranchised grief, which is that my grief hasn't got value. I can't demand space for my grief because in some ways it will take away from those that are more deserving of the space. If I say, look, I'm really distressed about this, it will take away from the family's experience, which again is a bit like the idea there's not enough love to go round. There's not enough space for grief to go around, so I can't, make a statement about my own grief. And this is a quote from a consultant from the group that I run. That the suicides of my patients haunted me. I was enduringly traumatised by some and became avoidant. It's like the security services on the Westminster Bridge, waiting for it all the time, and then when it happens, the first few days afterwards are awful and panic-stricken. Having to talk to the family at that stage is one of the most difficult things to ever have to do. There are different stages to my response. At the beginning, shock and numbing, then there's a serious incident inquiry and the inquest. It's very difficult to bring yourself to do the coroner's report, to revisit everything and be afraid of what you'll discover. Everything reads differently compared to when you wrote it. Sometimes the inquest can feel fair and give some resolution, and sometimes it's terrifying. To stand in the witness box and be cross-examined by the family sometimes for hours, always maintaining a professional stance, editing one's emotional responses. It's really hard, not being allowed to say anything publicly about how you might be feeling. So just a little bit about the psychodynamics of suicide, which I touched on. That the internal experience of the person who dies is projected into the external environment, and this can unleash very, very powerful persecutory forces. That there's an arrest in mourning, and the projections that are given can't be returned. So the very, very, very powerful feelings that drive suicide then get projected into people who are left around. And what we see in the group, and I think this is probably true in a lot of cases for many people after a death by suicide, that if I tell someone, and I've done it lots of times now, that a patient they're working with, who they might know very well, has died by suicide, they will be utterly shocked. Utterly shocked. They will often say, gosh, they weren't in my top 10, which is quite a weird concept anyway, because I don't think they have a top 10. But anyway, they will often say this. And I'll say, are you really shocked? Really, really shocked? Were you expecting this? Not at all, not at all. Within 20 minutes, they've started constructing a narrative. They start constructing a narrative with themselves as the protagonist. So they start, so 20 minutes later, I talk to the same clinician, and they'll say, actually, the last time I met with her, she said something about this, and so you can already see it. After 20 minutes, she's starting to make this connection, this narrative. By the time we'll see people in the consultant suicide group, or further down the line, within a week, there is a very strong narrative. And the strong narrative is, I'm the protagonist, and it is my fault. I am to blame. I have done something, I have made a mistake, and it is my fault. Now the trouble is, this is held in a delusional way, so powerfully, it is of a delusional nature, because it can be extremely weird. People can have very, very weird narratives where themselves are the protagonist and how they knew. Really, I had a colleague who was absolutely convinced the woman who died had sent her a personal letter, that she knew that this had happened. So I've seen this more than once. She knew it had happened. There's no evidence at all that any letter was sent, and she spent months looking everywhere for this letter, looking absolutely, totally convinced that this had happened. Very, very powerful and delusional, or almost delusional. What isn't delusional about it is if someone talks about it, it shifts. You can, the reality of the situation can flood in. But the trouble is, because people believe it so strongly, they believe they really are to blame, and it really is their fault that this person has died, that they really are a murderer in some cases. They can feel I'm a murderer. That they're not going to talk to anybody about that, because they know if they talk to people about it and say, look, this is what happened, that people will say, they're convinced, that people will say, oh my gosh, it is you. It was you. So they can't expose themselves in that way, so they get stuck for many, many, many years believing that they are to blame for someone else's death. But, however, if there are therapeutic, and I was thinking about your environment of where there has been a suicide in the school, You know, this happens not just in clinical environments, but you see it within, you know, we're talking to it now, starting to talk to it in clinical environments, but it must be happening within schools and other environments as well if someone has died. Extremely powerful. It traumatises the whole system. And the whole system feels ashamed and anxious, and if we start talking about it, we're going to find out we're to blame, so we can't talk about it, and the trauma gets stuck. Yeah. So, pattern of response. And it's very interesting, if we have someone that comes to the suicide group, quite often, you know, they'll say, well, tell us the story, and they will tell you the story of them, not the story of the person who's died. And they'll tell you the story of them, and you say, well, okay, now tell me the story of the person who's died. It's like, oh, they haven't even noticed that that isn't the story at all. It's their story. So within a very short space of time, everybody is very shocked. Short space of time, the narrative is constructed with the clinician as the protagonist. It becomes obsessional and delusional that I have made a mistake and I am to blame. They feel terribly guilty, in the way that I described it myself, toxic, shame, humiliation, and it's a very important transitional point, very sensitive to external response. And gradually, more realistic development can occur. So what a lot of the work I'm involved in is trying to get, what I feel is that this trauma is in us and in our services, and probably very much in schools and these environments that you're all working in as well. Now, if these traumas go untalked about, unengaged with, it affects the unconscious of the whole system. That if we can talk about it and try and revisit these things, it relieves everybody and everything. And I think then makes the chance of acting, both in self-harm and suicide, less. So this is that it's a profound unacknowledged trauma that we're only just starting to talk about. And we had the first conference the Royal College of Psychiatrists has ever had 2 weeks ago on the effect of suicide on clinicians. And it was the most well-attended day conference they've ever had of very profoundly traumatised people, many like very old male psychiatrists who came and were saying, well, I've never talked about this, never talked about it. So I will end the presentation there and just open for some more questions for another few minutes.
Thank you. Just want to pick up on what you said about the inability to mourn. Do you think there's any link to the fact that we are quite a grief illiterate society, and that the human condition is we all die? But when you said people are shocked by it, I mean, I understand that. People are shocked by any bereavement. And I just wonder whether we should be more open about grief awareness.
Yes, absolutely. Well, there are two parts to that. There's the part about grief awareness, and there's also another part you're talking about well, we're shocked by death, which I'll handle both of those. So absolutely, I think there's something about culture and grief that really has a very important part to play. But then also in other countries where there is a less illiterate grief behaviour, there is often a terrible stigma around suicide. So there are different factors at work here. But absolutely, there's something about grief, and I don't know whether you've seen, there's been a wonderful initiative called the Good Grief Festival, which is that, again, I think there is more about mourning. There's more about mourning on the television. I think probably quite linked to mental health as well. So I hope it is changing. They're starting to talk about grief and mourning more. I mean, we've all been universally through a very major loss event that we're all all mourning together at the moment. So yes. The second bit is, I think there is something different about the majority of deaths by suicide, however, than other deaths. And I think it's to do with it being what's called a projective event. So it's a very powerful statement and communication as well as a death. So I think that makes it sort of harder to mourn. It's as though the inability to mourn gets projected into everybody around, and suicide then, because of the shame and the humiliation and the sense of blame, personal blame and guilt, it makes it very difficult to mourn. So this is also why I'm here, trying to say that, come on, let's unplug a bit and let's try and mourn.
Thank you very much, that was really informative and useful. Sort of comments and questions, if you don't mind. So we spoke on the table earlier, and a lot of us are sort of doing similar things within schools. So we've got a group of friends who are consistently self-harming. I know self-harming doesn't always lead to suicide, but that group also, quite a few of them have attempted to end their life by suicide and ended up in hospital. Again, the same kind of friendship group. And the attempted suicides were quite shocking and surprising because we weren't expecting that. But then we've got another pupil who we know who is really high risk, and she's planned out everything she wants to do and said this is how she wants to end her life. So really it's just kind of any advice or suggestions on how to deal with that kind of behaviour within the friendship groups. And also any advice on sort of approaches with the two sort of different groups, because you mentioned obviously the impulsive, which we are dealing some pupils like that, but then we've got this one girl in particular who's premeditated, she's got everything planned out, she says she's going to do. So any sort of advice or...
So there's two different things I was thinking there. I was thinking, look, I think there is a difference. I think we're dealing with different groups, and I think we're talking about different groups, and I think they get very blurred. I think the group of people who've died by suicide are a particular group. And I think those people that self-harm are a different group to that. I think the only membership of this group you can be sure of is if someone has actually died. And I think they're often a very different group than the group that self-harm, although there's some overlap. Self-harm, so that in the way that you're talking about. Self-harm in itself, someone presents with self-harm to, for example, A&E, their chance of dying by suicide is 30 times higher than any member of the population in the next year, which still doesn't make it incredibly high, but it's an important indicator. Yeah, but I still think it's a different group because you're including, that's a very mixed bunch. I think what you're talking about is if someone is communicating about it, that's very different from the people that die by suicide who don't. So there's something about the communication and the acting out in the group you're talking about, which feels very important. And it's the people that self-harm are communicating in a very primitive attachment way. They're communicating with you through anxiety and fear and guilt, not verbally. So the working with it is again a bit like what I'm saying about dealing and talking with people who are suicidal, is to try and get something out of the acting out and into the words. So the more therapeutic input, trying to put into words what's happening, and not get anxious. The other thing is also, there's something about the therapeutic input and trying to put the feelings of distress, taking the feelings of distress seriously and trying to put it into words, but without acting out oneself. It's very difficult because it's a very primitive way of communicating. So there's something about how to calm you and your environment's anxiety, because what can happen is if the environment gets hyperstimulated, then it triggers everything that works. It's something about keeping the environment calm, that this is okay, this is someone trying to communicate in the only way they know how at the moment. So how do we change the culture here to put more into words and not be frightened about trying to do that?
Hi Rachel, I just wondered, you've touched a little bit on that when people get to the point where they feel very suicidal and they're in crisis point, and then there's that kind of little bit of a gap where they start to feel a bit better, almost find the energy to be able to do that. Is that a time that we can kind of come in when they've got a bit more capacity to think, or don't we get that opportunity?
I think what you see is that at that point, I think the theory is that people are what's called deep affected. So the group that go on to die by suicide have decided, they've made up their mind, and they've taken the energy out of the communication, so they wouldn't be communicating about it or making you feel anxious, because there's no point, they're not communicating anymore. So I think it's really very difficult in that group, because you're going to think everything's better. What you see time and time again is saying, I really thought that they turned a corner, they seemed much better. What can you do with that?
Hello, Rachel. I don't know if you can help me with this. Recently, we've had 4 attempted suicides at school. and one ex-student who did commit suicide recently, which has affected us all quite a lot. I class myself as a very resilient person who's been in the business for about 20 years and dealt with the murder of a student and various other things. But in the last 2 or 3 weeks, this has got to me. And I think the hardest thing is, obviously I use all CAMS work and I know I can contact them at any time. But my difficulty is when they come back to school after being hospitalised and I have their paperwork and that the school will carry on and help support, great, that's fine. My biggest worry is how soon do they go back into full-time education? Am I pushing them too soon? Should I put them on part-time tables? I just don't know the right thing to do.
Can I come at it a different way, which is to do with the trauma that's probably in your system, in you and in your team and in your organisation. And maybe the thing to work with is that trauma. Because if you work with a team, maybe it also links to the previous question, which is working with a team to try and process the experience of trauma from these, because it is very powerfully traumatic. And what it was reminding me of when you were talking there is the fear that's inside, that you might do this and then it's wrong, and then it's going to happen again, and then you're going to feel responsible, and then you're in a paralysis. And it's really, I think it's about taking you psychically out of that situation, maybe in reality also out of the situation, but it's psychically and saying, well, look, this is about you and your team, and let's work with your trauma. And by doing that, and what you see in the services where we work with teams who are traumatised, is actually the whole atmosphere in the wards and in the environments calm down, and the self-harming behaviour often calms down as well. The anxieties get fed through the system in an unconscious way.
Hi, I just wanted to ask, when you talked about grief and you were saying about the inability to mourn, currently working with a selection of students. One student's lost her father a few years ago and she's made repeated attempted suicide attempts. I think my curiosity is more about 2 other students that I'm working with, where both their parents, both mums, have had terminal breast cancer. And they're still both with us, luckily, but obviously they have gone through both similar situations. Mum's had breast cancer, then gone into remission, and then cancer has then come back elsewhere. They have made repeated attempted suicides. With that, then I'm thinking the inability to mourn, but they've already gone through that process of trying to mourn, thinking they were going to lose that parent, and now we've come back round and we're having to do the whole thing again.
Self-harming and suicidal thoughts are part of the mourning process, yeah. So a normal part of mourning is suicidal thoughts. If we're honest with ourselves about that, we might be able to tune into that in ourselves, but a very normal part of mourning is there's a part of the mourning process which is about guilt, anger, murderousness, suicidality. That's a very normal part of mourning. And it could be that these young people, by self-harming, are getting themselves through the mourning process, if you like. They're at that point of mourning. It's just about whether they can be helped through and past it. For young people, the capacity to put feelings into words, the capacity to mourn is incredibly complicated. If you really think about how hard it is for all of us to translate feelings, which are somatic, physical felt experiences, recognise symbolically what that is, put it into a word, and then be able to verbalise it to ourselves and other people, that is something that not many of us manage to actually really do very well. So actually mourning and being able to translate these feelings, a lot of us will have suicidal thoughts, and quite a lot of us will self-harm in one way or another, whether in a way that we would recognise and say self-harm. What about smoking, drinking, excessive destructive behaviour at certain points in mourning? And the problem is that destructive behaviour can get us a bit stuck there. But if we can be helped to get through it, not to be panicked about the suicidality or the self-harm, it's nothing to panic about. It could be a sign that someone is trying to get through that part of the mourning process and just needs some facilitation to get past it. They're stuck. So it's not something to be worried about. And this poor young person, is quite a very serious mourning that they need to do, isn't it, really? That's really very difficult.
Everyone really, on the difficulties with mental health and suicide, is that I think it's the stigma and the perception of what mental health is. And I think that, and I say this to my patients a lot when they come to see me, you know, they are often apologetic if they are coming depressed or anxious. They often feel like they need to explain themselves as to why they're not coping and why they're there. And I often point out that if they were having an asthma attack, they would not be sitting there going, oh, it's my fault, you know, doc, it's my lungs. They'd be saying, give me the help, give me the medicine that I need. And that also, when someone does die from suicide, whoever you are, again, it's that stigma of could have done something about it, which is actually, as doctors, if we have any sudden deaths, the automatic thing for any GP or doctor to say is, oh my God, who's the last person to see them? Was it me? But if you had a child in a school, or you had a child at a surgery, and you gave them every treatment you could, and you called the ambulance, and the ambulance came, and they went to A&E, and they sadly died because the asthma was too far gone, as much as that would be devastating for everybody around, there would be very little blame to go around because everybody did the right thing. And I think the message that I'm getting from you is for us to kind of understand is that sometimes there is nothing that we've done wrong. It isn't something that we've done wrong, or we could have intervened to do something about this.
And it's a hugely simplistic narrative to think that we have.
Yes, absolutely. And part of that is going to be having to change the whole stigma that's attached to mental health in general. Because there is still that thought that there's something that the person themselves could have done differently, which if they drop dead of a heart attack, no one ever sits there saying, oh, if you quit smoking and you've done this, then it's just, oh my goodness, they've died. And the same way, I wouldn't be sitting there beating myself up saying, oh, well, I could have maybe suggested something else. But with suicide, everybody seems to want to take that blame.
Well, that's right, and I think maybe that just leads to a final point, is there is one group would say that suicide is a terminal illness. It just doesn't, you don't see it till after the death. Yeah. So I'll just finally with that. So I don't tend to go with the accidental. What I tend to think is they're involved in a particular type of suicidal fantasy. There's a particular suicidal fantasy called dicing with death. So it's not quite, you know, they're dicing with death, and they think they're going to live. Do you know what I mean? It's a bit like, we see it's like Russian roulette. If they had a fancy of Russian roulette, if someone is playing Russian roulette, there's something very suicidal going on. There's lots of complex etiology to the point where someone is playing Russian roulette, but they have a fantasy that they are not going to die. You see it with the wingsuit flyers. You know, their life expectancy, I don't think, is particularly high for wingsuit flying. But, you know, again, there's a whole group of dicing with death. So I would say, yes, maybe they're not expected to die. I don't know whether I would think it's accidental, because again, that gives us the fantasy that if we'd have just done something different, we could have saved them, or it's an accident. So they've sort of fallen over something, rather than actually something very powerful, a force going on in them that's very powerful.